Dermoid cysts. Definition: it is a cystic teratoma. What's a teratoma? Teratoma is an encapsulated mass with normal tissues or organ components different from the surrounding tissues. It may contain hair, teeth, bone, brain, thyroid, liver, or lung tissue. Photographs of Teratomata. Causes of dermoids. Congenital sequestration of epithelial elements deep to the skin surface. This is congenital dermoid. Acquired or iatrogenic implantation of epithelial elements deep to the skin surface. This is the implantation dermoid. The contents: orderly, arranged, developmentally mature solid tissues. Contents: frequently contains skin and its appendages, hair follicles, and sweat glands. Other common components may include clumps of long hair, pockets of sebum, blood, fat, bone, nails, teeth, eyes, cartilage, or thyroid tissue. The fate: almost always benign due to the slow growth and the mature contents. Rare malignancy in the form of squamous cell carcinoma in adults. Endodermal sinus tumor in infants and children. Endodermal sinus tumor. It is also known as yolk sac tumor, a member of the germ cell tumor group of cancers. The most common testicular tumor in children under 3 years of age, also known as infantile embryonal carcinoma. This age group has a very good prognosis. Adult endodermal sinus tumors are often found in combination with other kinds of germ cell tumors, particularly teratoma and embryonal carcinoma. Pure teratoma is usually benign, but endodermal sinus tumor is malignant. Dermoid cyst sites. It can occur whenever or wherever a teratoma can occur. Ovarian, periorbital, external or internal angular, spinal including post-sacral, along the lines of embryological skin fusion, sublingual, superficial or deep, post-auricular, and pre-auricular. Ovarian, periorbital, external angular, internal angular, spinal, lines of embryological fusion, sublingual and submandibular, post-auricular, pre-auricular. Implantation dermoid, periorbital dermoid. Periorbital dermoid mostly appear in young children, often near the lateral aspect of the eyebrow. Periorbital dermoid. Medial, internal angular dermoid cysts might point to the possibility of an encephalocele. Spinal dermoid. Spinal dermoid, extremely rare, more often in the lumbosacral region, extramedullary in position, presenting in the first decade of life. Ovarian dermoid. Ovarian dermoid. It has rare incidence. Abnormal differentiation of ovarian totipotent germ cells present at birth, developing characteristics of mature dermal cells. Implantation dermoid cysts. Implantation dermoid clinical picture occurs in patients having repeated minor injuries, affects mainly the fingers, the palm, and the sole of the foot. Hard consistency due to the thick overlying skin. Teratomatous dermoid cyst. Teratomatous dermoid cysts arise from the totipotent cells have ectodermal, mesodermal, and endodermal elements occur in the ovary, testis, retroperitoneum, or mediastinum. Tubulo-embryonic dermoid. Tubulo-embryonic dermoid arise from ectodermal tubes, the thyroglossal cyst and the post-anal dermoids are examples. Clinical picture. It appears in childhood or in adolescence. It is painless, slowly growing, swelling. It is present at the lines of embryological fusion. It is soft, cystic, fluctuant, yielding on finger pressure and not slipping away, unlike the lipoma. Transopaque on transillumination and putty in consistency. No impulse on coughing might be present with communicating ones. Maybe underlying bone defect clue to the diagnosis. Differential diagnosis. Epidermoid cysts, including the sebaceous cysts. Encephalocele in communicating dermoid cysts with bone defect. Epidermoid cysts. Epidermoid cyst, benign. It is a benign cyst usually found on the skin, composed of ectodermal tissue only, histologically made of a thin layer of squamous epithelium. Differentiation from sebaceous cyst. This is a sebaceous cyst photograph. Sebaceous cysts occur on occlusion of the ducts of the sebaceous glands, but dermoid cysts occur either on congenital sequestration of multipotential cells or on implantation of the skin elements deep to the skin surface. Sebaceous cysts occur on hair-bearing body areas like the back, face, neck, scalp, or scrotum, but dermoid cysts occur along the lines of embryological fusion. The overlying skin is attached to the sebaceous cyst by their occluded duct, the punctum, but is not attached by any means to the dermoid cyst. A punctum is always present in sebaceous cyst, but it is always absent in dermoid cyst. Sebaceous cysts contain toothpaste-like whitish foul-smelling material, but dermoid cysts contain ectodermal, mesodermal, and endodermal tissues or organ parts. Sebaceous cysts never show intracranial communication, but dermoid cysts might show intracranial communication. Investigation. Most of the dermoid cysts don't need diagnostic investigations. CT scanning for suspected communicating dermoid cysts and cysts with underlying bone defects. Complications. Inflammation on its disruption or recurrence on incomplete excision. Torsion, rupture, or infection of ovarian dermoids. Recurrence on incomplete excision. Care for medial internal angular dermoid cysts, which might point to the possibility of an encephalocele. Good luck and best wishes.